Hey guys, I am going to review chapter 63 of eye disorders. I made this PowerPoint back before Christmas, so hopefully I can remember everything I put in it. I'm going to try to keep this short, as short as possible, and then I'll try to have the vision one done by the weekend so you guys can study. So I'll get started and share my screen. All right, so okay. So real briefly, like I said, I'm not going to spend a lot of time on anatomy and physiology when we go through these chapters, but I just kind of like to review it really briefly. So just, of course, look through your book and know the different parts of the eye, or just be familiar with the medical terminology for those different parts, because you're going to see, documentation and different things like that. You just need to be familiar with what they're called: the conjunctiva, the canthus, the lacrimal sac, those different medical terms in there, where they're at and everything. So many of the leading causes of visual impairments are associated with aging, and we're going to talk about a lot of different disease processes: cataracts, glaucoma, macular degeneration. So let's just talk a little bit about the different muscles that we have. We have 4 muscles right here. Again, just a little anatomy and physiology review. Normally, the movement of the 2 eyes are coordinated and the brain perceives a single image. So, pop quiz: what are the cranial nerves that help us see? If anybody knows. So, cranial nerves, 3, the oculomotor, 5, the trochlear, and 8, the abducens. So oculomotor, trochlear, and abducens are our cranial nerves. And then again, the cornea. So we have the cornea here and the lens. Those help us to focus the light rays on the back of the eye, which is the retina. And then we have the optic nerve, which transmits from what we see with our eyes to our brain. And the retina is an extension of the optic nerve. Viewed through the pupil, the landmarks of the retina are the optic disc, the retinal vessels, and the macula. The point of entrance of the optic nerve into the retina is called the optic disc. The optic disc is either pink, is pink and kind of like either circle or oval shaped. It has pretty sharp margins, so like when the ophthalmologist looks at it, it's pretty easy to see. It looks like a cup. It kind of has a depression, so it kind of looks like a cup. It's kind of concave, and it has obviously lots of blood supply and vessels come from it. And the macula is the area of the retina that's possible for our central vision. The rest of the retina is responsible for peripheral vision. 2 important layers of the retina are the retinal pigment epithelium, or the RPE, and the sensory retina. The RPEs have numerous functions, including absorption of light, and the sensory retina contains the photoreceptors, which are our rods and cones. I'm sure you guys kind of remember a little bit about this. The rods are responsible for night and low vision, and our cones are essential for our visual acuity, our color discrimination, and our fine detail. So that's just a little review there. And then again, here's kind of that picture that shows the impulse where our optic nerve transmits the impulse from the retina to our occipital lobe. The optic nerve leaves the eye and then meets the optic nerve from the other eye, and they cross. So that's just a little picture of the visual pathway and kind of how that works. So there is chart 63.1 in your book. I would just look over that and review the pertinent questions to ask when you're taking an ocular history. It's a good little table in your book to just review. So does the patient have the experience blurred, double, or distorted vision? Which eye does it affect, one or both? Do they have pain? Are they having discharge? And do they have any history of eye conditions or eye surgeries? We test our visual acuity with the Snellen chart. I'm sure everybody's had a Snellen test at some point in their life. And this tests our far vision, right? what's the lowest line they can read accurately is what we are trying to determine with the Snellen chart. So a 20/20 vision is considered normal. So let's say someone has a 20/40 vision, that means that they have to be 20 feet away to read something that other people can read from 40 feet away. This would be difficulty with far vision or myopia. So myopia is impaired far vision. If the patient cannot see the big E on the Snellen chart, then you could have fingers at varying distances to test their vision. So if they can't even see that big E, then we can get our hands closer to their face and, you know, ask how many fingers can you see that I'm holding up. To test close vision, we use that Rosenbaum test, and this allows them to see the chart 14 inches away and see what's the smallest line they can read without difficulty. And this is testing for impaired near vision, which is presbyopia. So myopia is impaired far vision, impaired near vision is presbyopia. So know your terms, your medical terms for what those mean, because you'll see them at some point. And then our external examination of the external structures of the eye. So we always want to look and inspect the eyes, the eyelids, the pupils, the sclera, and the conjunctiva. So when we're looking at the eyelids, do we see like any swelling, any drooping? Is the sclera white and shiny? What are some things that we can see that sometimes the sclera is not always white? So that's an indication that maybe something's going on. For instance, we know when we see the sclera is yellow that we have jaundice. Is the conjunctiva pink? It should be pink. If not, is it swollen? Is it red? Are we seeing discharge? And then we'll want to assess obviously our pupils. You guys should know how to assess pupils, right? But we're looking for a pupil size that should be 3 to 5. And of course, they need to be equal, round, and reactive to light and accommodation. So reactive to light, we're going to dim the lights and have the patient look at that object from a distance, and then shine the light from the side of each pupil. And we want to note when we shine the light, the dilation and the response. So, you know, does the pupil go from a 3 to a 1? And the other side should constrict as well. And then when we're testing accommodation, we want the lights to be normal and have the patient look at a distant object to dilate the pupil, and then have them stare at the pin light slowly and move it closer to the patient's nose. And the pupil response should constrict and equally move to cross. So that's how we check that accommodation, right? Okay. Look for strabismus. Strabismus is, does the eye line up with one another? So are we having regular eye, or is one here and one down here? Have the patient follow your pin light and move it 12 to 14 inches from their face in the 6 cardinal views of gaze. And we're watching for nystagmus, which is any involuntary movement of the eye. So if you've ever seen anybody with nystagmus, it's pretty cool, but their eye just kind of like twitches back and forth. So that's another thing we can assess for. So what are some diagnostic evaluations we have? Obviously ophthalmoscopes. We can have direct and indirect examinations. Examine the cornea, the lens, and the retina. The slit lamp, I'm sure you guys have all been to the optometrist and you see that little thing that they shine that really bright light through a small slit. And that enables them to look at the cornea, the lens, and the retina. Excuse me. And it magnifies it 10 to 40 times so they can see, you know, all the little fine details. The color vision test using the Isahara test, and I'll maybe show that to you in class, but I'm sure you've all kind of seen, you know, or taken a colorblind test at some point. Color visions can be inherited and are more common in males. They can also be secondary to medications or cataracts if they have color distortion problems. The Amsler grid is a tool that we use to detect problems with the macula. So we can have, which is that center part of our retina. And it's where you have the patient look at this grid, these like line grids. And if they look at it and they're wavy instead of straight, then they're having problems with their macula. So that's like the earliest, easiest detection test that you can use for macular degeneration. It's called the Amsler grid. So those are just some different types of additional tests. Then the fundus photography is used to detect and document retinal lesions. Tonometry is used to detect for intraoptic pressure to screen for and manage glaucoma. And there's lots of different angiographies that they can do. Contrast dye to look at the retinal vascularization. So nursing interventions, anytime we give contrast dye, just remember that we want to assess the patient's kidney function and make sure, that they're not obviously allergic to the contrast. And then specifically with this one, we want to watch for bleeding and hematoma formation. And what are some different types of impaired vision? We kind of talked about near and far vision earlier. So in refractive errors, vision is impaired because we have a shortened or elongated eyeball. And this prevents light rays from focusing sharply on the retina. So if your eye is shorter or longer, then the retina is not able to focus those light rays quite like it normally would. So some people have deeper eyeballs, in which case a distant visual field focuses in front of or short of the retina. So those with myopia are said to be nearsighted and have that blurred distant vision, and other people have shallower eyeballs, in which case the visual field focuses beyond the retina. Those with hyperopia are said to be farsighted and have adequate distance vision but blurry near vision because of the shape of their eye. With astigmatism, the front surface of the eye or the lens inside the eye is curved differently in one direction than the other. And a common symptom for this is blurry vision from any distance. So I have like all of these. So bring my glasses to class one day and let y'all see how thick they are. They're pretty pitiful. Let me move this over so you can see. Well, it's kind of blurry right there. So vision impairment is defined as having best corrected visual acuity of a 20/40 or worse in the better seeing eye. Low vision describes visual impairment that requires use of devices and strategies to perform visual tasks. Could be me. And legal blindness ranges from inability to perceive light to having some vision remaining. And I think the technical term for legal blindness is that even with corrective lenses, that's the best that you can see. So because technically without my glasses, I'm legally blind, but with my glasses, I get pretty close correction. So those are the different classifications. So when we're assessing somebody with low vision, we want to know what's their daily routine? Do they have ADL limitations or not? For some, it may be that they have to have someone prepare their meals for them, or maybe they can't tell the numbers on the microwave or the stove. So they maybe actually put salt in their smoothie or cumin in their oatmeal thinking it's cinnamon. So they just have difficulty performing their ADLs. What aids do they use? So do they use magnifying glasses? Do they use talking watches, talking alarm clocks, different things like that, because maybe they can't see the numbers, and so they use those devices to help. We have contrast sensitivity testing. This measures the visual acuity in different degrees of light and dark contrast to determine the visual function. A glare can reduce a person's ability to see, especially if the patient has cataracts. So those affected by loss of contrast sensitivity and glare have difficulty functioning in low light or driving at night. I definitely have trouble driving at night. It's kind of like you're taking a gamble if you get behind the wheel with me at night. Half of those who are legally blind are over the age of 65. There's table 63.1 in your book, and that summarizes age-related changes in your eye. So I just kind of look over that. The refractory changes with loss of accommodation. So they must hold objects far away. So you always see those people who, you hand them something and they're holding it as far as away as they can get to be able to see. Cataracts, we'll talk about in just a second. We'll talk about some of those different ones. Let's see. Table 63.2 in your book shows low vision aids. So just be familiar with, what some of those are. Magnifying glasses, screen magnifiers, large prints. You can have buttons that you push that talk, as in my spare time watching TikTok. And there's a girl on there that I follow, and she's blind, and she was showing how she has these little like buttons that she can record. So like she had gotten some kind of like sauce, and she put the button on the sauce, and then she hit it on her phone and recorded like what it was. Like her boyfriend or significant other told her what it was, and then she recorded it, and then all she had to do was like scan her phone over the button, and then her phone would talk to her and say, hey, that's your Chipotle sauce or whatever. It's like she would pull things out of the fridge and then just scan over it, and then it would talk to her and tell her what it was. And I'm like, that's really cool. Like the technology nowadays to help people with disabilities is pretty awesome. I may need it some days, so I don't know. Yeah, so there's just lots of different assistive devices out there that can be of assistance with our patients. Many of those people with vision impairments may have different, emotional coping stages, just like with any other disease process. They may initially go through denial or anger, or, just depending on the gradual onset or quick onset of their vision loss, how they handle it, and different various things. But just know that they may cope at different paces than others. There's also a table 63.3 in your book. I believe that kind of discusses that as well. So when you are helping a patient adapt with vision disorders, you want to knock and always identify yourself as soon as you enter the room, because it makes them really nervous when they hear somebody in there and they don't know who they are or what they're in there for. Just imagine like, you're sitting in the room and you can't see anything, and then people are coming and going and you don't know what's going on. It's very, it can be very unnerving, I would think, for them. So knock and say, hey, my name's Blaine. I'm your nurse. It's Blaine. My grandma had macular degeneration, and she lost most of her eyesight by the time she was like 65. And me and my sister, our voices sound very, very similar. And so when we would call her on the phone, or we would, go to visit her, I'd have to say, hey, Grandma, it's Blaine, because she couldn't tell my voice from my sister's voice, and she obviously couldn't see us. So we always had to tell her who we were. But it just kind of puts them at ease, just to know, like, okay, who is this? That's coming in my space. Allow them to hold just above your elbow when you're guiding them to walk. So if you're, walking them, allow them to hold onto your arm, like just above your elbow, not around your shoulders ever, but just as you're walking them. So, they're kind of taking the same steps and same movements as you are. When we help them sit, you want to place their hands on the arms of the chairs to help guide them, or let them tell them, okay, back up and feel the back of the chair with the back of your legs, and then have them put their hands on that. And then they can kind of feel where that seat is, and they'll be more comfortable, getting into that seated position, because they can feel it, obviously, because they can't see it. Be specific when we are giving them directions. Don't just say walk 20 feet to your right, because that's kind of hard, right? We can use a clock face. We're going to use a clock face for a lot of different things, but you can say, hey, that's at 12 o'clock from where they're at, or 6 o'clock, and that's a little bit easier for them to kind of maneuver. Offer to read written materials, or modify the way, obviously, that we educate the patient. Obviously, we can't go in and say, hey, read this over and let me know if you have any questions. We're going to have to sit and read it to them. So, and then we want to orient them to where things are in their environment. So if we take in a breakfast tray, we're going to sit it on there, and we're going to tell them exactly where everything's at. So, and we used to do this for my grandma too, but she would get her food, and we'd say, okay, your eggs are at 2 o'clock and your bacon's at 5 o'clock. And so she could kind of feel, she would take her hands and she would feel the outside of the plate, and then she would know, okay, because she's seen a clock face in her life. So she would know, okay, 12 o'clock. So she'd feel her plate and she'd know at the top of the plate where 12 o'clock is that's where her eggs were. So it's just a helpful way for them to be able to, know the placement of items, within their area. And then obviously assist them in setting things up and opening things up and just letting them know where it's at so they can try to reach it the best they can. I'm skipping her. I made this back before I started recording my lecture. So ophthalmic medications. So let's just talk about some of the things that affect the medications that we get. So we have a limited size of our conjunctival sac. The conjunctival sac can only hold 50 milliliters of fluid at a time. The volume of one eye drop from a commercial topical ocular solution typically ranges from 20 to 30. Corneal membrane barriers. So we have the epithelial, stromal, and endothelial layers that are barriers to absorption of those medications. And then we have the blood ocular barrier that prevents high ocular tissue concentration of most of the ophthalmic medications because it separates the bloodstream from the ocular tissue and keep foreign substances from entering the eye. So that can kind of limit our meds efficacy, right? And then we have tearing, blinking, and drainage. So we have increased tear production when we put those meds in, and drainage due to irritation. Sorry, so we put those in and it may dilute or wash out some of our instilled medication. And then obviously, a lot of people don't like it, the sensation, so they blink a lot, and it creates that and makes it worse. So aqueous solutions are most used for the eye. They're the least expensive medications and interfere the least with vision. However, corneal contact time is brief because, again, the tears dilute the medication. So ophthalmic ointments have extended retinal time and the retention time in the conjunctival sac and provide a higher concentration than eye drops. So there's disadvantages to both, but the major disadvantage of ointments is the blurred vision that they'll have temporarily after the installation of the medication. Topical anesthetics. So these are medications that they can put in to numb the eye if they've got like a corneal abrasion or they've had, impalement of a sharp object. But these can only be used for short term, so 1 or 2 doses, because they can cause the cornea to soften and to be damaged. So I don't know if you guys have ever had any kind of numbness, but they'll usually only give you 1 or 2 doses of that, and then you can't just use it liberally however you want. Let's see. Mydriatic potentiate alpha adrenergic sympathetic effect that results in relaxation of the ciliary muscle, but this is a short-acting effect. So mydriatics here. So they dilate, but it's short-acting. So we would use in conjunction with our cycloplegics, which paralyze. The cycloplegic medications are given to paralyze the iris sphincter. The side effects include glare and focus problems and can last hours to a couple of days. Usually direct them to wear sunglasses to help with glare. These affect the central nervous system and can increase blood pressure, cause tachycardia, dizziness, confusion, disorientation, and they're going to be contraindicated, in patients taking MAOIs and tricyclic antidepressants. If the patient has a history of high blood pressure, then we want to let the physician know and monitor the blood pressure really closely when we're given these topical anesthetics. Anti-infectives, so antibiotics, antifungals, antivirals, like we would maybe use for herpes or cytomegalovirus, they have similar side effects and adverse reactions as our oral agents. So I would review chart 63-4, instilling eye medications. I know you guys have checked off on this in Skills Lab. I helped a lot of the ALTIS people check off on this last year, so I know you know how to do it, but just review it. If you had to give drops or ointments, which one would you give first? Know that. We would want to give drops first, right? Because if we gave the ointment and then the drop, we know that increases tear production and could, wash that ointment out. Absorption of eye drops by the nasal lacrimal duct is undesirable. So we don't want that, right? Because the potential systemic side effect from our ocular medication, so they can be absorbed systemically through that nasolacrimal duct. So to diminish this, we want to minimize that. It's important to include the punctate or the puncta. So you do that just by basically like pushing on the bridge of the nose, and you just want to occlude right there in the corner of the eye for 1 to 2 minutes after the installation of those drops. So basically you're just blocking it from draining into that lacrimal duct so that it doesn't get absorbed systemically. And you want to do that for 1 to 2 minutes after you instill those drops. And if we had to give multiple drops, like if I had to give an antibiotic drop and then a glaucoma drop or whatever, a different type of drop, how long would you need to wait in between drops? 5 minutes. So we want to wait 5 minutes in between drops so that they can have enough time on the surface to be absorbed. And then we want to wait 10 minutes between ointments. So if we have multiple ointments to give, we would wait at least 10 minutes between those. Okay, so getting into the nitty-gritty of this, glaucoma. So glaucoma is a group of ocular conditions in which there's damage to the optic nerve in relation to our intraocular pressure, because we have aqueous humor that gets congested and can't drain out like it normally does. Glaucoma is more prevalent in older people older than 40, and is the third most common age-related eye change in the United States. And there's a chart 63.5 that shows those risk factors. So intraocular pressure, what does that mean? So that means intra means in, right? So that means in the eye. So pressure within the eye, right? So the fluid or the pressure, this is meaning aqueous fluid. So we're talking about our aqueous fluid that is causing pressure buildup. So intraocular pressure is calculated by the production rate and drainage rate of the aqueous humor. Most aqueous humor drains out through the trabecular meshwork. These fun medical terms, right? But we have it kind of, they call it meshwork because it's kind of like just a little place of tissue here that has several little holes where our aqueous fluid comes and washes the back of the cornea here and then drains out this trabecular meshwork into the Schlemm's canal. That's fun to say, Schlemm. The canal of Schlemm. So if the production rate and drainage are not equal, then we're going to have this fluid that is being produced and is flowing through here. But if we've got a problem with either the trabecular meshwork or the Schlemm's canal, then obviously this fluid is going to back up and it's going to build up and it's going to put pressure on the optic nerve. So we're going to have high intraoptic pressure, and this can cause irreversible mechanical or ischemic damage to that optic nerve, which is not good. Let's see. Let's make sure I'm not missing anything. Yep. Okay. So there's different types of glaucoma that we are going to talk about. So there's wide angle and then narrow angle. So open angle or a wide angle glaucoma, the problem is not with the angle, but the actual meshwork. So you remember we talked about that trabecular meshwork right here. So the meshwork can actually become clogged as we become older and just become thicker and like less permeable. So the aqueous humor doesn't flow through as fast, and that fluid collects and then again places that pressure on the optic nerve. And this is the most common type. And this happens very gradually, very slowly, and they actually call glaucoma the silent thief because many people don't even know they have it until they start experiencing the vision loss from having that intraoptic pressure causing damage to their optic nerve. And this is not reversible because it's causing that ischemic damage to their optic nerve, and we can't reverse that ischemia. So that's why they call it the silent thief. So best for early detection if we can, in this people who have older population, they should be tested for glaucoma. And then we have the narrow angle or the closed angle. So the aqueous humor cannot even get down to the trabecular network to drain out of the eye. And this is an anatomical defect. So let me go back to this little slide of your, the eye here. So the angle, that's why they call it narrow angle. So the angle to get down in here is cut off. So it's not that it can't get through, it's that the angle is so narrow that it can't drain through. This, like I said, is an anatomical defect. So medications that dilate the pupil, anticholinergics are what we use. This is rare, but our signs and symptoms are way more noticeable, and this requires immediate attention. It's not silent. They're going to have severe pain, nausea, vomiting, halos around the lights, blurred vision, edema to the cornea, and a very, very high intraoptic pressure. So early detection is key. Exam of the eye. Optometrist is going to look at the optic nerve and the optic disc. In glaucoma, the disc can have a cupped shape. And we can measure the intraocular pressure by using a device called a tonometer. And normal IOP is generally 10 to 21 millimeters of mercury. And the gonioscope can measure angle drainage. So they can use that to actually measure like the angle to see if it's so narrow that it's not draining. So again, with our immediate treatment for acute angle glaucoma, again, this is a medical emergency. It's not silent. They're going to have a lot of pain, a severely elevated intraoptic pressure, corneal edema, and a pupil that can even be fixed in a semi-dilated position. Again, this is a medical emergency. We're going to give eye drops and oral medications to lower the intraoptic pressure, and we'll talk about those meds in a minute, those anticholinergics, along with surgical procedures. So they can do what's called either an iridotomy or an iridectomy. The iridotomy is where they actually go in and drill a small hole into the iris with a laser and let the actual aqueous humor just drain out the front of the eye to relieve that pressure in the acute phase. And then the iridectomy actually goes in and removes permanently a part of the iris. So that's how we would treat that. General guidelines for administration of the eye drops: always wash your hands before you touch your eyeballs, or before you touch a patient's eyeballs, or teach your patient to wash their hands before they touch their eyeballs. Hand washing is super, super important. And then they need to take it exactly as prescribed. So glaucoma is not curable, but we can use these medications to slow the progression of the visual loss. And these are like, you're going to have to take these for the rest of your life type medications, like we've talked about before. It's not curable, but we can treat and manage the symptoms with the medications. So they need to know that they're always going to have to take these meds, or they're going to be back to where they were with increased intraocular pressure, and whatever vision they have left, they could lose if they don't maintain it. So that's important that we educate them on that. If administering more than one, again, we're going to wait those 5 minutes and make sure you occlude the puncta when you're giving those medications, because we don't want them to absorb systemically. So again, our treatment is first-line medications, eye drops, oral meds. We have alpha agonists. Activates alpha receptors and constricts the ciliary body, which decreases the aqueous production. So we're just making less aqueous fluid. Punctal occlusion is really, really important with these medications. So the alpha agonists, because they can be very drowsy afterwards if we don't. Beta blockers. This decreases aqueous humor production. Crazy, right? So punctal occlusion is very important, because if we're giving a beta blocker through the eye and it gets absorbed systemically, what could happen? It could block beta everywhere, not just the eye, right? So we have to be careful with that. And again, when are we going to be really careful with using beta blockers with anyone? Our asthma and our COPD patients, right? Because we don't want to block the beta in the lungs. So be careful with that. Again, making sure you occlude the puncta is really important with all these medications. And then we have carbonic anhydrase inhibitors. Those decrease the aqueous humor production, and diuretics that can inhibit carbonic acid production. And these are contraindicated in patients with sulfa allergies. Cholinergics, so we talked about those miotics. Those increase aqueous fluid outflow by contracting the ciliary muscle and causing meiosis or constriction of the pupil and opening of the trabecular meshwork. The antidote for this is atropine, if you ever need to know that. Increase eye sensitivity to light and other cholinergic side effects. So you guys remember when we kind of way back last semester when we talked about mental health and cholinergic side effects. So be familiar with what your cholinergic side effects are. And then we have prostaglandin analogs. They end in prost. These have less systemic side effects and can cause thickening and longer eyelashes. Girls, do we need these eye drops? I think we do. But this can also cause a brownish tint to the iris. So you may have poop brown eyes, but you'll have long, pretty eyelashes. Okay, so those are the medications that we are using to treat these and kind of how they work. And then our surgical treatment, we have the selective laser trabeculoplasty. Say that 5 times fast. So this is when they use a laser to open up that trabecular meshwork. And then obviously then that's going to help the fluid drain and lower our IOP. And then a trabeculoectomy, where some of the trabecular meshwork is actually removed. And then our aqueous humor then is going to collect in the conjunctiva, and this can cause what's called a bleb. So you see this right here is what's called a bleb. And eventually that aqueous humor just gets reabsorbed, but I would think that that looks maybe uncomfortable. So post-op education, we need to make sure they keep their follow-up appointments, educate them on signs and symptoms of infection. And it's important that they keep those appointments so that we can continue to measure their intraoperative pressure and make sure it's continuing to trend down and not going back up. We also need to tell them, this is pretty much with any eye surgery, that they need to take stool softeners to keep and drink lots of water as long as it's not contraindicated, so they can have soft BMs. And why would we want to have soft BMs? So that when we're taking bowel movement, we're not straining, because when we're straining, what does that do? That increases our intraocular pressure, the pressure behind our eye. And if we already have a lot of pressure behind our eye, or we've had a recent surgery, that's no good. So we don't want them to strain to have a BM. All right, skipping that. All right, so skipping that one as well. We'll do questions in class. Cataracts. Cataracts and opacity or cloudiness of the lens, increased incidence with aging. By age 80, more than half of the American population has cataracts. So if you live to be 80, there's 50% chance you're gonna have a cataract. It's the leading cause of disability in the United States. Age is the biggest risk factor. And then we have 3 types: traumatic, congenital, and senile, which is obviously age. Leading cause of blindness in the world, affects over 18 million people. We have opacity in the lens of the eye. Again, aging, it has to be caused by retinal detachment, herpes in the eye, chemical burns, smoking, long-term use of corticosteroids, and diabetes. So what are our clinical manifestations in people who have cataracts? They can have painless, blurry vision, and a decreased visual acuity. So and this vision loss is painless. They can have double vision as well and see halo around the lights, and also have photosensitivity. And then you notice when they do a exam that they're going to have an absent red reflex. You guys remember what the red reflex is from fundamentals. Diagnostic findings include decreased visual acuity and opacity on that lens when you look through the ophthalmoscope with inspection. Cataract removal is a very common surgery. More than 1 million people have this surgery performed in the United States every year, so it's pretty common, right? So the nurse needs to ask the patient about a history of taking alpha antagonists. This can cause intraoperative floppy iris syndrome. Some of these things that just made me laugh. Intraoperative floppy iris syndrome if they're on alpha antagonists. So just a little negative wisdom there for you. Phacoemulsification. This uses an ultrasonic device to suction the lens out through a tube. incision is smaller. So they basically just kind of make a little incision and then suck the lens out through a tube. Kind of crazy. Lens replacement after removal of the lens. The surgeon inserts the intraocular lens implant, and this eliminates the need for the harder lenses, but they still may be required to have glasses even with that. So we're going to have similar post-op instructions with glaucoma surgeries. So we want to have educate on how to take their eye medications. It's really important. Also, we talked about not straining with having a BM, but there's other things that we do on a normal daily basis that can increase our intraocular pressure, and that would include lifting heavy objects, straining, or bending and stooping, increase intraocular pressure. So we don't want them to bend and stoop. We don't want them to lift anything heavy. We don't want them to strain to have a bowel movement. So we want to do those activity restrictions for them within the first few days. We don't want them to drive until their ophthalmologist tells them it's safe to do so, and that's usually after their first follow-up appointment. They need to wear protective sunglasses when they're in direct sunlight, and they are going to have mild vision impairment, and that's going to get better after 4 to 6 weeks. I think a lot of people think, oh, I'm going to get my cataracts removed and then I'm instantly going to be able to see better. It's a gradual improvement in your vision, but it takes 4 to 6 weeks after surgery to kind of get to that point. You want to instruct the patient to call the physician immediately if they have vision changes, continuous flashing lights appear, redness, swelling, a severe increase in pain, or significant pain that's not relieved with whatever pain medication they're taking or over-the-counter meds, because this could be signs of increased intraocular pressure or retinal detachment. Corneal dystrophies. These are inherited and are autosomal, and they manifest at around 20 years of age. We have deposits. You can see how thick and exaggerated this is. So we have deposits in the corneal layers. Keratoconus is the most common type of corneal dystrophy. It's characterized by conoconal protuberance, using some big words today, of the cornea with progressive thinning or protrusion and irregular astigmatism, so they're going to have blurred vision. Fuchs dystrophy, I think that's how you say it, because I'm not going to say how it looks like you're saying. Fuchs dystrophy is manifested by slow death of cells in the endothelial cornea. That's most common. Phototherapeutic keratectomy, PTK, laser procedures used to treat these diseases. So that's probably all you need to know about that. Other important ones, we have retinal detachment, and that's a big one that we need to talk about. So retinal detachment, we have the separation of the sensory retina and the RPE. Manifestations are that sensation of a shade or a curtain coming across their vision. So it starts outside, and then, because remember, our retina, our macula is our central vision, so they're usually going to lose that peripheral vision first, just depending on where the retina is detached, and then they say it's like a shade or a curtain, drawing. So they're going to lose that first, and then usually narrow in on their central vision. Bright flashing lights or sudden onset floaters. So, every once in a while you say maybe 1 or 2 floaters, but this is going to be like floaters everywhere, and to the point where it's like totally obstructing your vision. So this is a medical emergency. So we always tell patients, like, hey, you need to, if you ever have this, contact your ophthalmologist or whoever, like, right away. And some people will come to the ER for this too, and then they'll contact ophthalmology to get them seen. So diagnostic findings, we're going to assess the visual acuity and the retina using the ophthalmoscope and the slit lamp. So what do we do for a patient who has a retinal detachment? Well, we try to put the retina back on if we can. Okay, so the way we do that is there's a couple different ways you can do it. So they can do a scleral buckle, which basically they insert this, I don't know if it's made of plastic or what it's made of, but it's a synthetic material, and they basically, where their retina has attached right here, and they put this little thing on it. It's called the buckle, and it basically just holds the retina down in place where it's supposed to be. It compresses the sclera. And then we have the vitrectomy, and this is where they'll inject through the back of the eye. They can either use a gas bubble, silicone oil into the back side of this eye, and it basically kind of works like this buckle, but it's a big circle of gas or a big circle of oil, and it compresses on that retina and holds it down. So the important thing to know when you're discharging somebody who's had this procedure is that they have to lay prone. Usually for at least a week, not all hours of the day, but usually they have to lay prone for 45 minutes out of every hour, so they can like get up and go pee and like eat or drink or whatever, and then for 15 minutes out of every hour, and they need to stay down. And the reason is, as you know, we have that gas or that oil, and so if they keep their head down, that's keeping the gas and the oil pushing down on the retina and keeping the retina in place until it's had a chance to heal. So they need to stay laying prone. So my boss actually that I worked with before, she had a retinal detachment in one eye, and then she had her retina detached in the other eye. But she went through several of these surgeries. She had some kind of weird condition where she kept making scar tissue and her retina kept detaching. But yeah, it was pretty miserable. And her family went and bought her like a massage table so that she was comfortable when she had to keep her face down. So like she had a massage table so at least like her face could, not be smushed in a pillow, because she had multiple surgeries over like a 2 or 3 year period. But yeah, and then again, the same kind of instructions that you're going to give the people who have had any eye surgeries. We don't want to increase any kind of pressure, snub bending, stooping, heavy lifting, things like that. When to call if you have pain, redness, nasty looking drainage, those things like that. And then, of course, sudden loss of vision again, which means the retina can have detached again. So they would want to report that right away. And then we have age-related macular degeneration. This accounts for 54% of blindness in older adults. We have the dry or non-exudative type, which is the most common, and then the wet type. The dry non-exudative just basically means it's a slow breakdown in the layers of the retina, and then the wet is like abnormal blood vessels growing. So that's why it's called wet, because it's blood vessels. Blood vessels are wet. That's not really super important for you to know. Early detection, regular eye exams are key to finding this, because they can look at your retina and kind of tell like whether it's looking healthy or what it's looking like it's being degenerated. So when you go to your regular eye exam, usually they'll ask you if you want to do a retinal scan. If you've had like a family history of it, I would definitely recommend it. I get it done every year because my grandmother had macular degeneration, and I also have been told my eyeball is so long that it's at risk for a random retinal detachment just because my eyeball is so long. So who knows? I could lose my vision at some point, but I told my husband he's just gonna have to be my seeing eye dog. So recommendations to improve lighting, magnification devices, refer to a vision center. So there's lots of different things that they can do to help these people. But right now, we can only slow the loss of vision. We can't restore the vision with age-related macular degeneration. So just be aware of that. Infectious and inflammatory disorders. We have dry eyes, we have decreased tear production, obstruction of a lacrimal gland, certain medications, allergies, people with contact lens. If they don't take their contact lenses out or they sleep in them, it can be really bad. So they can have these type of problems. Conjunctivitis is inflammation of the conjunctiva, obviously. Foreign body sensation, scratching, burning, itching, discharge can be watery, mucoid, or purulent. Bacterial conjunctivitis, most common is Streptococcus pneumoniae. They can also get chlamydia, and that is sexually transmitted. I'll never forget, I had a friend that worked in the ER, and she said a guy came in and he had told them that he got pink eye from a stripper. So guess be careful with that. The common causative organisms are adenovirus and herpes simplex for other conjunctivitis. The conjunctivitis caused by the adenovirus is highly contagious. That's our pink eye. So we have that cold compress, artificial tears, don't share towels, wash your hands, discard any eye makeup like mascara, things like that is considered contaminated and they need to throw it away and start over. Orbital cellulitis, this is inflammation of the tissue surrounding the eye. It can be caused by bacteria, fungal, or viral. Infection of the sinuses is the most frequent cause. So it can infect the sinuses and then cause, obviously, orbital cellulitis. They look like, all swollen around their eye. It looks very uncomfortable. Immediate administration of high-dose broad-spectrum antibiotics. They're going to culture any drainage, and then monitor for changes in visual acuity. And then central nervous system function. So nausea, vomiting, fever, or any cognitive changes. That orbital cellulitis. Okay. And then ocular trauma. So this can, of course, come from many different things, but common ones are sports, weapons, firearms, shoot your eye out, kid. Occupational injuries, like people who work in, mechanics or welding and things like that. Motor vehicle accidents are very common for ocular injuries. Chemical burns. Anytime you have somebody with a chemical burn to the eye, it has to be flushed, like immediately. So they do training with people who work with chemicals at the job site, that if chemicals come in contact with their eye, they need to be flushed on site prior to coming into the emergency room. So those are going to be irrigated with tap water or normal saline on site before transfer. And then, of course, again, irrigated into the emergency department when they come in. Foreign objects should be protected from jarring, and we don't want to remove them. This can cause further ocular damage, so we want to cover it with a metal shield or something to protect it from getting jarred, if possible. And then corneal abrasions. This is really common with contact lens wearers because they don't take their contact lenses out. And, they can get things stuck underneath them, and it can cause abrasions to the cornea. So they would use antibiotics and steroids and patch, and they can actually put a therapeutic soft lens over top of the corneal abrasion, and that can help with discomfort. So, all right, that is the quick nitty-gritty of this chapter, and I will try to get the sorry, it's been a long week already, it's only Wednesday, the hearing chapter up by Friday so that you guys can have time to watch it over the weekend. So that's all I have for you, and I will see you tomorrow for our test. Have a good night. Bye.